All right, so today we're going to be looking at abnormal uterine bleeding. So before we get to the abnormal, let's just kind of talk about what is normal uterine bleeding for a female. The normal is primarily been characterized with a few criteria. So the first thing is the frequency. So the frequency is generally 28 days, but this can be plus or minus 7 days. So that means anywhere from 21 to 35 days. The frequency, and then the second thing is going to be the duration. So let's just write frequency here. That's one way to describe it. Then we have duration of once bleeding begins. How long is it bleeding for? This is anywhere from 5 to 7 days. This is normal. And then finally is the amounts. So on average, a woman will probably lose anywhere from let me erase that, from 20 to 60 milliliters of blood. And this is obviously kind of hard to measure. A lot of times they measure with how many pads they use or comparisons to previous menses, but it's tough to do, tough to measure. So just by carefully asking questions and using different forms of measurements, you can figure that out. So if that's normal, let's talk about what's abnormal. So when we're talking about abnormal, there's a few different things that we might be looking at. We might be talking about menorrhagia. Menorrhagia means excessive amount of blood flow or just high blood flow. And this could either be a high duration. So for example, it's going to be lasting greater than 7 days. So they might be having the menstruation for a week and a half to 2 weeks, or just a high amount of blood quantity. So they'll have anywhere from greater to 80 milliliters. So either if it's lasting very long or they're just a heavy flow, both of these would be characterized as menorrhagia. Then we have metrorrhagia. In metrorrhagia, we're not really talking about the flow per se, we're talking more about the frequency. So in metrorrhagia, there's more frequent, but the amount of blood will be normal or maybe even less normal. And finally, there's metrorrhagia, and this is a combination of the two. So in this case, you have a high blood flow, either duration or amount, plus you have it's very frequent. So even in between cycles, they're already bleeding. So this is the general definitions. How do we, main categories of this are generally based on the age. So we have premenarchal, which means before they have the onset of menses, and this is generally considered less than 12 years of age. Then we have this, and then we have postmenopausal. So these are kind of alarm symptoms, and then obviously you have bleeding during the reproductive age. We'll tackle that last. There's a lot of causes for that. We'll kind of take these two first because they're going to be a little bit more straightforward. So let's start with premenarchal. What can cause this? So let's look at causes first. The variety of causes. The first thing, the most common cause is foreign body. So maybe they'll, kids, do funny things. They might put something physically up their vagina, and then that will cause bleeding to come from that, or infection. And the other thing that you also want to rule out is sexual abuse. Sexual abuse can sometimes present as bleeding from the vaginal area. So that's also something you need to keep in mind. Secondly, they could be taking some sort of endogenous estrogen, and this leads to something called precocious puberty. So it could be, they might be taking the mother's OCP pills, if it's the combined type, or it might be something, they might be having some type of tumor or cancer which is secreting estrogen, and that's the third cause. So any type of cancer, such as vaginal cancer or cervical cancer, can lead to that. And of course, cervical cancer, you want to do pap smear. And then there's a specific cancer in this age group, which is called sarcoma botoroides. And this is actually really easy to diagnose because as soon as you do a pelvic exam, you'll see this grape-like structure coming out of it. So that's fairly easy and straightforward to diagnose. And then not only tumors in the genital area, but you can also have adrenal tumors and pituitary tumors. And so in these tumors, there might be secreting estrogen, and this is leading to precocious puberty, which will lead to menarche at a very young age. So how would you want to work up a patient with this? Of course, the first thing you're going to want to do is you're going to want to do a pelvic exam, and you're looking for the foreign bodies. You're looking for any signs of sexual abuse, any cancers or growths or tumors that might be coming out. And actually, you also want to make sure which site is it coming from, because sometimes it might be coming from the urethra or it might be coming from the rectum. So you want to kind of rule out those two causes specifically. If that looks normal, then you probably want to do some imaging, either CT or MRI, because with the physical inspection, you can pretty much rule out foreign body, you can rule out sexual abuse, all those things, but you can't rule out, you can even rule out, vaginal cancer, cervical cancer, but you can't rule out some of these tumors, maybe adrenal tumors. So you're going to want to do MRI of the pituitary gland. You're going to want to do an MRI of the abdomen, and you're also going to want to maybe do an MRI of the pelvis. So that kind of is an overview of the premenarchal causes. The second one we're going to look at is going to be the postmenopausal causes. Postmenopausal, the causes can be grouped into primarily three categories. There's benign causes, malignant causes, and what I like to call exogenous causes. So what are your benign causes? Benign causes is going to be atrophy, because in this age group, in the postmenopausal age group, estrogen goes real low, and so there's nothing for the endometrium to stay stimulated, and so you might get endometrial atrophy, and on top of that, you can get vaginal and cervical atrophy. And so when these atrophy, the skin becomes very friable, very weak, very thin and narrow, and so that can lead to bleeding as well. So fairly benign. You would treat it primarily by maybe giving estrogen. If they have hysterectomy, you can give those. You can give estrogen if they have hysterectomy already. Now, there are some malignant causes. One of them is going to be ovarian carcinoma. Ovarian carcinoma can release estrogen, and so this can kind of lead to unopposed estrogen and lead to dysfunctional uterine bleeding, which we'll talk about in a little bit. And you can also have tumors of the vulva, of the vagina, and the cervix. So all those tumors as well. Exogenous, a lot of times women are taking hormone replacement therapy to help them with the hot flashes, or help them maybe they have osteoporosis, anything like that. They might be taking it, and this can lead to bleeding. And they can also be taking anticoagulants. So if they have a heart condition, they might be taking warfarin, and then that might lead to increased bleeding. Now, for evaluation, there are certain cancers which are much more prevalent in this age group. So the first thing you want to do is you want to assume it's cancer, and you want to treat it like a cancer case, and until it's ruled out. So you will primarily start with a physical examination. You might even want to start with a general examination. Make sure that, because they are losing blood, make sure that their vitals are fine, that they're not in any type of hypotension or tachycardia. That's important. But after that, you can do a more specific exam, of the vagina. Here's where you can notice atrophy. You'll notice the walls. There won't be any fornices, and also you want to pinpoint the location, because sometimes urethral and rectal bleeding can be confused for vaginal bleeding. So you want to first just kind of confirm it's coming from the vagina. And again, just by looking, you can rule out many things, such as atrophy of the vagina, and other things as well. Secondly, you primarily want to focus on the endometrium, and you want to go ahead and try to rule out cancer. And so you can do that in two ways. You can do a transvaginal ultrasound, but the gold standard is definitely biopsy. So you want to try to get a biopsy of the endometrium. And finally, your next attention will be focused onto the cervix. So you're going to want to do cytology of the cervix to rule out cervical cancer. Treatment will depend on what the underlying cause is. Obviously, if it's one of the cancer, you're going to treat those according to the principles underlying cancer treatments for those specific tumors. And if it's atrophy, you're primarily going to be looking at giving maybe HRT. And of course, if it's HRT, you want to stop giving that. And anticoagulants, maybe you want to decrease the dosage of whatever they're taking or give them something else. Okay, so the final one is going to be abnormal uterine bleeding in the reproductive age. So, of course, bleeding during this time is very, it's normal, but abnormal bleeding, you do need to figure out what's going on. So, let's first talk about the different causes. There's many, so I'm going to give you a big list here, but just try to bear with it. The first thing you want to definitely rule out is pregnancy, because they can get pregnant during this time, and so of course you're going to give them beta HCG, and so this can either be an ectopic pregnancy, they might be having an early abortion, or it might be molar pregnancy. So these are three things you definitely want to think about first. The second thing is they could be having some abnormal growth. This can be leiomyoma. Leiomyomas can cause this, and just if it was a leiomyoma, how would you treat it? You treat it with a uterine artery embolization. So that's how you do that. Besides that, you could also be an endometrial polyp or endocervical polyp. So you can just have a polyp being formed and causing bleeding there. Next, we can look at external causes. So they might be doing something, it's outside the body that's causing this. One of the reasons could be an IUD, either the copper or the Mirena, which we talked about in the other video, and the other can also be OCPs. So either the COCP, the combined one, or the progesterone-only pills. It can also be if they're on hormone replacement therapy for any reason, and even tamoxifen is known for doing that as well. More causes, right? You can have an infection. So an infection can cause this. So endometritis, which is kind of a postpartum thing a lot of times, and this is the caused by the gonorrhea and trichomonas as well. Those all can cause that. Even bacterial vaginosis can lead to this type of bleeding. Mycoplasma as well, which is another common cause of vaginal and gynecological infection, and PID, of course. So infections higher up can be there as well. Next, there are some systemic causes. What are some of the systemic causes? Liver failure. So I'm thinking, they have decreased coagulation factors, can definitely cause that, and even renal failure. Renal failure can cause it as well, and thyroid. Thyroid problems can also be there. Coagulopathy. So any of the coagulopathies, hemophilia, von Willebrand's disease can cause this as well, and thrombocytopenia as well, of course. So anything that has to do with the blood's ability to clot and coagulate can definitely cause it. Now, say you cannot, it's not a pregnant, there's no growths, they're not taking anything, they don't have an infection, no systemic causes, then it gets labeled as DUB, dysfunctional uterine bleeding. This is pretty much means idiopathic, they don't really know what's going on. This is broken down into two groups, anovulatory and ovulatory. So anovulatory is ovulation is not going on, so you just have unopposed action of estrogen, because in order for the regular menstruation to occur, you have to have ovulation, which creates the corpus luteum, which creates the progesterone, and then progesterone withdrawal will lead to menstruation. If you don't have that, estrogen keeps building up, the endometrial wall gets thick and thick and thick, and finally it falls, sloughs off, and so that can be a very common cause of diffuse uterine bleeding. The other one is going to be ovulatory. They don't really know why it occurs, but what the current idea is, you have increased prostaglandin, which is going to decrease the vascular tone, or in other words, it's going to cause vasodilation. And so when bleeding happens, it's a lot of bleeding, just because all these vessels in that area are dilated, and so you get much heavier bleeding than usual. And why do you think prostaglandins are involved? Because this tends to get better with NSAIDs. So that's going to be the causes. What's also important that we look at is going to be workup. So if you get a patient, what are you going to look at first? Which way you're going to go. So like we discussed earlier, the first thing that we want to rule out is pregnancy. So get your beta HCG right away just to make sure she's not pregnant. And that's not only important for figuring out the cause, but if they're pregnant, there's many things you can do. And you also want to check the CBC to make sure they're not too anemic, because they are bleeding. So that's something you just want to take a look at real quick. What else would you want to do? You can do a pap smear just to rule out any HPV or cancer of the cervix. You can do something called a wet prep. And so what happens in a wet prep is you get some of the cervical secretions and you put it in a saline solution, and then you take a look at it. And so that's your pretty much a wet prep in very simplistic terms. Finally, you want to take a look at the endometrium. So there's many things you can do. Again, you can do hysteroscopy, which is a current way to go about doing it. You can do it dilation and curettage, which is a little bit more invasive, and then you can get the Pipelle device, which kind of you kind of pull the device in there and just kind of scrape a little off. But I think the one of choice is hysteroscopy, because there you can look at it with your eyes, look around, see how everything is going on. You want to do an ultrasound as well. How does an ultrasound help you? Firstly, it's going to be able to identify any polyps that might be in the area, or fibroids that need to be, so you need to rule that out anyways. So ultrasound can definitely help with that. But it can also help you with looking at endometrial size. So the endometrial size is normally, so the normal is 8 to 11 millimeters. Now, if someone has hyperplasia, which will occur in the non-anovulatory DUB, it's going to be greater than 8. It's going to be, sorry. Normally it's 5 to 8 millimeters, but in hyperplasia it's going to be 8 to 11 millimeters. And if there's a cancer, it'll be even greater than 11 millimeters. So that's just by doing an ultrasound and taking a look at the endometrial thickness, it's going to tell you a lot of information. So how do you want to treat it? Of course, depending on the underlying cause, that will gear the treatment, but just remember NSAIDs can really help because they block that prostaglandin effect. Contraception is a very common way, especially if it's dysfunctional uterine bleeding. It can help in that. You might also want to give antifibrinolytics just to make sure, just to kind of decrease the bleeding. The most common one is going to be tranexamic acid. And this is used in dysfunctional uterine bleeding as well. And you might want to give some iron supplements just to make sure she doesn't become anemic. And finally, there are some surgical options. If you can use dilation and curettage, and maybe if they don't want to have any more babies, hysterectomy. So that is pretty much the causes of abnormal uterine bleeding. Hope you guys enjoyed. Thank you very much.